session. I'm going to discuss nerve conduction studies. I will try to cover motor, sensory, F, and H waves, reflexes. Now, why do we do motor nerve conduction study? It gives us information about the excitability of the nerve, which in turn reflects the status of the myelin. It tells us something about propagation characteristics, which is also dependent on myelin, as well as the diameter of nerve fibers. We know there are some pathologies that affect small fibers, while others affect large fibers. It gives us information about how many axons are preserved in the nerve. This is important when looking at progressive diseases such as motor neuron disease. And sometimes our nerves don't follow the traditional course. We have so-called anomalous innervation, which can be confusing in interpretation of data. Let's see how a motor nerve conduction is done. I will use the median nerve as an example. We need 3 recording electrodes. The black electrode is called active, or E1. We have a red electrode, which is called reference, or E2. And then we also have an electrode usually in green color and green wire. It is placed nearby these electrodes. In this case, it's on the dorsum of the hand. We measure the voltage difference between the active and reference electrodes and analyze the response. We use a stimulator, which has got 2 pins. One is the black pin, called the cathode, and the red pin, which is called anode. The cathode is placed over the nerve to stimulate the nerve. So here is an example of such recording. I'm going to increase the stimulus intensity gradually and notice a small response. As I increase the intensity, the response becomes larger. Now it's not changing. So we increase the intensity by another 20% and call it supramaximal. Once again, look at the recording. Start at low intensity, no response, slight response, it's getting bigger, more, it didn't change, and now we will make it supramaximal. Having recorded the signal, we can make many different measurements. The most common ones are the latency and amplitude. So this is the response. Here is the stimulus artifact. The nerve starts conducting action potentials. And when it reaches the muscle, there is neuromuscular transmission, activation of muscle, and here is the response. So the onset marker is placed at the first deflection from the baseline. This is the peak, and the voltage difference between markers 1 and 2 is called the amplitude. So these are the primary measurements that we do at wrist stimulation. And we have normal limits for it. In this case, the latency is 3.25, and you can see it is highlighted in green color, indicating it's within normal limits, and so is the amplitude. Let's look at a little bit details on how this response is generated. Here is a model where you can see there are axons over here, muscles on the right. When you stimulate over here, and let's stimulate at very low intensity, this may stimulate only one axon. The action potential goes to the muscle, and we get a small response. What is that small response? Here are more details. Single axon, that comes to the muscle divides into several branches, each branch making a contact with one muscle fiber. This is actually a motor unit. So when we stimulate one axon, we excite all muscle fibers innervated by that axon, and we are recording the response on the surface. So this is nothing but the surface motor unit action potential. It is important to recognize that the time of conduction involves propagation along the myelinated portion of the axon, where it is fast, but in the terminal branches, it may be slightly unmyelinated or less myelinated, so the conduction is slow. We also have the time for neuromuscular transmission. So the latency that we measure from a single stimulation doesn't reflect the action potential propagation along the axon. And as a result, you cannot calculate velocity in a motor nerve conduction study from a single stimulation. Another thing to notice is when we are stimulating supramaximally, we have got axons propagating at different speed. Each axon produces its own surface motor unit potential. And these potentials are not synchronized. This is called temporal dispersion. We do not see the individual potentials. Rather, we look at the sum of all of these responses, which is the compound muscle action potential. So the compound muscle action potential amplitude is a much more complex phenomenon. Notice that the onset of the compound muscle action potential coincides with the earliest S month, and therefore it is believed that the onset of the compound muscle action potential reflects the properties of the fastest conducting axons. There are some experiments that are published recently which indicate that that may not be the case. But for the time being, we will assume in today's lecture that it's the fastest axon that produce the initial deflection over here, or the onset latency. The amplitude will depend upon how many axons we have, as well as the amplitude of individual motor unit potentials and their temporal dispersion. So this was our distal stimulation. We define this site in many ways. Some people use a straight distance from the recording electrode to the stimulation site. Some use a hockey stick kind of measurement. And some laboratories use an anatomic landmark, such as distal crease, and then go 2 centimeters back. Any convention may be used, so long as you are doing it in a consistent manner and using reference values associated with the distance measurement. Now we stimulate the nerve proximally over here. Same principle. Let's increase the intensity and stimulate. Here is the response. We increase the intensity to get maximum response. Having obtained the response, we input the distance between the stimulation sites to calculate the conduction velocity. So this is a basic motor nerve conduction study where we focus on stimulating at least 2 sites, sometimes 3 sites. In proximal muscles, maybe only 1 site, and then we assess the latency, amplitude, and conduction velocity. So here is our summary results: latency, amplitude, distance, and velocity. If we were to superimpose the traces, you will see that there is hardly any change in amplitude. The waveform at proximal stimulation looks very similar to that at distal stimulation. There is a slight change, but not a very significant change. This is the pattern that is seen in healthy, normal nerves. Let's look at our conduction velocity. The formula is the distance between the distal and proximal stimulation sites. This is measured in millimeters, and we divide it by the difference between the proximal and distal latency. So when you subtract these difference, notice that we are taking away the time of nerve propagation in the distal segment over here. The velocity that we measure is specific of the segment between the distal and proximal site. The point I'm trying to make is that if you had a pathology somewhere over here, nerve conduction velocity will still be normal because that reflects the time of propagation between distal and proximal site. Similarly, if the lesion was somewhere more proximal, somewhere over here, this velocity measurement will still be normal. The point I'm trying to make is that just because there is nerve pathology doesn't mean that the measurement is abnormal. In nerve conduction studies, we try to stimulate the nerve at multiple sites so that we can localize the lesion. And that's the beauty of nerve conduction studies. Here is another method of superimposing the waveforms. I have aligned the waveforms on their onset point, and notice there is hardly any difference between the response recorded at distal and proximal sites. And this is something I and Professor Stolberg, along with Professor Barkhouse, reported recently. There is not much change in the waveform in healthy median nerves over here. But in pathology, that pattern may not hold true. And to investigate those changes, we can make additional measurements. So here is a measurement which is called relative amplitude. The amplitude is 13 millivolts at wrist. At elbow, it was 12.2, which is 93.8%. So this is one way of describing the amplitude change as relative amplitude. Some laboratories look at the difference. So the difference over here is 6.2%. And so they will report a decay by 6.2%. When we look at the duration is slightly increased at the proximal site. And the area is a little bit less, relatively unchanged. So that's the pattern of a normal motor nerve conduction study. The waveforms at distal and proximal sites are similar. They have very characteristic waveforms. In the median and peroneal or fibular nerve, you get a nice Gaussian or a bell-shaped waveform. In ulnar nerve conduction study, you may get two peaks in the upward going phase, and you can also get two peaks in the tibial nerve. But they have a generally monophasic waveform for the negative peak. So the waveforms look relatively similar. There is very slight change in the amplitude, duration, or the area. Why did the area decrease and the duration increase? Let's go back to our temporal dispersion. This is the way the individual motor unit potentials arrive at the recording electrode. And they are very synchronous. Here it is going up, this is going up, it's going up. So they add in a constructive manner, giving us a large signal. But if the temporal dispersion is increased, now some motor unit potentials occur early, some come late. And notice that the positive or the downward going peak of this potential coincides with the upward going peak of this response. And when added, they will cancel each other. This is called phase cancellation. And because of phase cancellation, we get longer duration and lower amplitude. The typical characteristics with increased temporal dispersion is amplitude decreases, duration increases, area decreases slightly, and this is often associated with increased latency and reduced velocity. Also, the waveform can have multiple peaks. So let's look at the anatomic correlates of our recordings. Latency can increase, and the primary mechanism is demyelination. Because of demyelination, action potentials will conduct slowly, and therefore they will take more time to go from the stimulation sites to the recording electrode. This is very similar to a traffic problem on a highway. If there are no issues on the highway, we reach there very fast. But if there is an accident, now you need to slow down, and it's going to take you longer to reach your destination. You can also get increased latency because of loss of fast axons. So this can happen in motor neuron disease. You are losing a lot of axons. Now you are left with slow conducting axons. They are normal. There is nothing wrong with their myelination. It's just that they conduct very slowly, and therefore the latency can be increased. This is usually associated with low amplitude. In motor neuron disease, you do not see this with normal CMAP or normal strength. Latency can appear reduced. This is not an absolute reduction. This is relative reduction, and that can happen due to anastomosis. For example, in Martin-Gruber syndrome, you can see short latencies for the median nerve with elbow stimulation. Or you can have phenomena such as cathodal migration that can cause excessive stimulation and give you a shorter latency of the response. So once again, I emphasize slightly increased latency or reduced velocity is still consistent with axonopathy. If we want to make a decision about demyelination, we often require a significant reduction in velocity. So here is an example in a patient with ALS. You can see this is the motor nerve response, very low in amplitude. The distal latency is increased, 4.85. The sensory nerve conduction showed a normal response over here, 82 microvolts normal latency. So in this case, we have lost a lot of fast conducting motor axon as expected in the patient with ALS. So you get normal sensory, but a delayed motor. This is not an evidence of carpal tunnel syndrome or anything. So watch out when you are looking at latency and velocity in ALS patients who have very tiny responses. Let's not overinterpret. Here is the data that Professor Barkhouse and I collected. On the x-axis, you can see the compound muscle action potential amplitude. On the y-axis, this is the distal latency. And these are our normal limits. And you can see that when the amplitude is normal, you usually get normal latency. Even when it is reduced, you can get normal latency. But in some subjects, you can get increased distal latency. The amplitude is again a complicated phenomenon. It can be increased due to anastomosis. You can stimulate extra muscles or extra nerves. Again, this happens in Martin-Gruber anastomosis. When you stimulate the median nerve at the elbow, you may get a higher amplitude compared to the wrist. It is not increased compared to absolute. It's just that we get a larger than expected response. In patients with neuropathy, the amplitude may initially be low, but it can increase because of renervation. Once again, it will never become more than normal. But for that patient on serial investigations, the amplitude can increase. And this is a very nice way to follow up the recovery from a nerve injury. the amplitude will tell you how the reinnervation is progressing. We can have reduced amplitude due to loss of axon, loss of motor neurons, loss of excitability, for example, in conduction block. So that's a classic example where we find the amplitude is reduced. And you can also have reduced amplitude because of increased temporal dispersion, where we start getting phase cancellation. So these are the neurogenic processes. This is motor neuron disease. This can be a conduction block, and this can be demyelination, which is causing reduced amplitude. In patients with primary muscle disease, we can also get loss of amplitude. That can be due to atrophy of muscle fibers, due to loss of muscle fibers. And although not indicated on this slide, you can also get reduced amplitude due to abnormal neuromuscular transmission. For example, patients with presynaptic disorders like Lambert-Eaton myasthenic syndrome, you will get low amplitude. So when the patient has low amplitude, the diagnosis is going to be more tricky because we need to check if it is a neurogenic process, a myopathic process, or a neuromuscular junction disease. Velocity can increase because of anastomosis. This is something that we see in patients with carpal tunnel syndrome who also have Martin-Gruber anastomosis. They get increased latency at wrist stimulation, but normal or even apparently shorter latency with elbow stimulation, giving a high velocity. But that is not a real velocity that reflects anastomosis. You can have increased duration due to increased temporal dispersion. You get more peaks because of increased temporal dispersion. The velocity is reduced due to demyelination, and it can also be reduced due to loss of fast conducting axons, as I indicated earlier. The duration can be reduced because of artifacts, particularly if wrong filter settings are used. If your low frequency setting is increased artificially or by accident to say 100 hertz, you will get a much shorter duration. So now let's look at the patterns of abnormalities that one can see on nerve conduction studies. So let's begin with a model of a simple or a normal nerve conduction study. So on the right-hand side, you can see the sketch where I have drawn the axon with the node of Ranvier on the side. So here is the axon. This is the myelin. This is the node of Ranvier. And you can see the saltatory conduction. This is my distal stimulation site. This is my proximal stimulation site. The muscle is somewhere over here. And I'm going to pretend that we are stimulating a fibular or peroneal nerve. This is the distal response at ankle, below fibular head, and above fibular head. The waveforms are remarkably similar in their appearance. The latency is normal. The amplitude decreases very slightly, and the conduction velocity is also normal. So whenever I look at a conduction study, I don't look at the numbers. I look at the waveforms, make sure that they are similar on successive stimulation, make sure that the onset marker and peak marker is placed properly. I will also check the duration marker. Sometimes this is important in demyelination. And when satisfied with the markings and the overall waveform appearance, that's when I look at my measurements. Also, it is important to look at the contraction of the muscle. Professor Kimura always used to emphasize, look at the muscle first when you are stimulating. Make sure that it is contracting properly, then look at the screen to look at waveforms. If the stimulator slides from your stimulation sites, you can still see waveforms on the screen, but they are generated due to volume conduction. So this is the pattern of a normal conduction study. Now let's look at a focal demyelination. Notice this is where I have demyelination. So when I stimulate distally over here, I have to go through this demyelinating area that slows down the action potential when stimulated distally, as you can see by the blue response over here. This is going to increase the latency. It is 5.1 milliseconds and abnormal. This demyelination is very focal. It doesn't cause any significant temporal dispersion. It doesn't cause any blockade of action potential propagation. And therefore, the action potential may be slow, but it does reach the muscle. And therefore, our amplitude is unaffected. When I stimulate proximally, the action potential also passes through this lesion. Note that the increased time of conduction occurs with distal stimulation and proximal stimulation. And in the calculation of conduction velocity, this increase is subtracted and cancels to zero. And therefore, the conduction velocity is normal. So in this example, with a distal demyelination, focal, we get increased latency, normal amplitude, and normal velocity. Before we go that, it is also very useful to make a side-to-side comparison to easily assess the change in the latency as seen over here. This is the abnormal side, and this is the response with wrist stimulation on the opposite side. Now we can have focal demyelination that occurs between the distal and proximal stimulation site. The previous example represented a situation that we'll encounter, for example, in carpal tunnel syndrome. This is a situation that will occur with a fibular neuropathy or injury at the knee. So when I stimulate distally at the ankle, the nerve is absolutely normal. And as a result, we get normal latency and amplitude. When we stimulate proximally over here, we have focal demyelination. Now, the action potential slows down a little bit, but does reach the muscle. And as a result, the amplitude is still normal. However, it has to slow down as we go from the proximal to distal side. And therefore, the conduction velocity is reduced. So the pattern of a focal proximal stimulation, focal proximal lesion that is between stimulation sites, is we get normal distal latency and amplitude. Our velocity is slightly reduced when it is calculated between the two stimulation sites. So in this case, you can see my stimulation site was between the fibular head and the knee. So the responses at ankle and fibular head are normal. At knee, the amplitude is normal, but the response is delayed, giving you a slower conduction velocity. And you can always compare the response with the opposite side to clearly see the side-to-side difference. Let us now look at diffuse demyelination. So this is where we have lost myelin over here, over here, over here. So this is like a highway that has got multiple accidents. You go fast and then you slow down, and then you go another few kilometers and then you slow down, and the process repeats. So this is going to affect our responses significantly. When I stimulate at the distal site, I need to go through the demyelinated area. And as a result, my distal latency is increased. Notice it is 9 milliseconds in this example. As I had indicated earlier, when you have increased temporal dispersion, you also get reduced amplitude. So in this case, my amplitude is also reduced. This can be due to increased temporal dispersion. And when I stimulate proximally, I see the same phenomenon. The latency is increased and the amplitude is also reduced, and the conduction velocity is very low. So the hallmarks of non-uniform demyelination is that you get a longer duration of the compound muscle action potential at all sites, And there are normative data available for the distal sides over here. So you get increased duration, you get increased latency, you get lower amplitude, uh, and you will also notice that the waveform is no longer bell-shaped. It tends to have a lot of notches. So it has a jaggedy edge kind of a response. These are the characteristics of non-uniform demyelination. This is typically seen in acquired demyelinating polyneuropathies. In contrast, if we have uniform demyelination, and this is something we call dysmyelination, so it is uniform over the entire nerve. And therefore, now you get similar looking waveforms at the proximal and distal stimulation. This is my distal stimulation. The waveform looks normal, but keep in mind my time base is 4 milliseconds per division. We typically record responses at 2 milliseconds per division. So this waveform is very, very broad. The important thing is that the waveforms look similar between the distal and proximal stimulation. So we have increased latency at both stimulation sites. We have reduced conduction velocity, and the amplitude, because there is not much temporal dispersion among the components, and because it is uniform, the amplitude can be relatively normal, though it is typically on the lower side, and the waveform also has a normal appearance, especially if you are compressing the sweep. So this is typically seen in inherited demyelinating polyneuropathies. So the nerve conductions can help us differentiate acquired polyneuropathies from inherited polyneuropathies. When the demyelination is extensive, the action potential may fail to propagate. And this is what is called the conduction block. So in this case, this particular axon cannot conduct the action potential. So when I stimulate distally, the axon is normal, and therefore you get normal latency and amplitude response. It has normal waveform. When we stimulate proximally, some axons that are not affected will conduct at the proper speed, but axons that are heavily demyelinated will fail to conduct action potential. And as a result, you get a much lower amplitude response. So you can see from ankle to below fibular head, you have got almost the same response with a delayed latency. But at above the fibular head, there is no change in the duration, but the amplitude is significantly reduced. The velocity may also be mildly reduced when the conduction block is severe. What is different is that the shape of the waveform looks normal. In demyelinating conditions, the waveform looks different. So it's always very important to look at the waveform of the potentials in the nerve conduction studies and not just look at the absolute numbers. So there are various criteria for conduction block. The conduction block is assessed based upon the change in the duration. And you can get low amplitude due to demyelination. You can get low amplitude due to conduction block. And therefore, there are criteria that are defined based on the change in duration. So here is some criteria from muscle and nerve that are shown on the right side. If the change in the duration is less than 30%, that means there is not a lot of temporal dispersion, then a drop in amplitude by more than 40% can be considered conduction block. But if the duration also change, then we need to see larger amplitude drop. And these criteria do vary. There are many different publications. Majority of the laboratories will consider a conduction block if the area or amplitude decrease is more than 50%, regardless of duration. Keep in mind, so far we have looked at a single pathology, but in many patients, we will get conduction block and demyelination together. So it's a combination of these disease processes, which is quite difficult to assess. And needle EMG can also be useful to look at some of the other phenomena. So in this case, my amplitude is low. It's 1 millivolt per division. So it's on the borderline. No, the waveform looks quite fine over here. But when I go to the proximal stimulation, you can see the increased duration, the drop in amplitude, increased number of phases, or increased number of peaks. So this is where we had a combination of a demyelination process. There is a conduction block, and there could be an axonopathy either. These are the conditions that are extremely difficult to study using nerve conduction alone. You can have a pure axonopathy where there is the myelin is absolutely normal, but we have lost motor axons. So here is an example of a 4-year-old with a musculocutaneous lesion. On the normal side, you have a normal response, but on the opposite side, the latency is normal, the duration is normal, indicating there is no defect in the myelin. Simply the amplitude has decreased. And a drop in amplitude by more than 50% is considered significant. It is important to look at the time of lesion. So this is the normal pattern. This is distal stimulation, proximal stimulation. You get normal responses over here. If you have pathology, and let's say it caused a lesion over here, I don't know if it is conduction block or axonopathy. And if I were to do the study immediately, notice that my distal response is normal, but the proximal response has lower amplitude. This can be axonopathy or a conduction block. I cannot tell. But if I were to wait for a couple of days, about 2 weeks or more, if it's an axonopathy, then we will have if it's a conduction block, then we will get the same pattern over here, that you got a normal distal response and a proximal response is small. But if it was axonopathy, then these axons will disintegrate and we'll get a lower amplitude response at both sides. So this is axonopathy. You'll get small amplitude at distal and proximal sides. Conduction block, a large response in distal, small response proximal. And finally, is this axonopathy? I have got normal latency, but low amplitude. As I indicated, amplitude also depends on the neuromuscular transmission. This was a patient with a Lambert-Eaton syndrome. And when we had the patient exercise, the amplitude became absolutely normal. So to summarize, the motor nerve conduction study tells us something about the myelin, that is the excitability of the nerve. It tells us about the propagation characteristics and fiber diameter. It tells us something about size of axons. And although we didn't discuss it, it can also help us study anomalous innervation. Sensory nerve conduction studies follow the same principle, except the main difference is the absence of a neuromuscular junction. We can conduct the study in 2 ways. We can do it antidromically, where we stimulate proximally and record distally. The action potentials are going from wrist to the fingers. This is the opposite direction of natural flow of action potentials. So that's why it's called antidromic. In the orthodromic method, we will stimulate the fingers and record the response from the wrist. Keep in mind, in motor nerve conduction study, although we call it a nerve conduction study, we are recording the responses from the muscle. And there is a biologic amplifier. Each nerve axon will innervate maybe 50 to 100 or even more muscle fibers. So you get large amplitude responses. In sensory nerve conduction studies, we are recording from low amplitude, short duration, individual sensory axon potentials. So the signals tend to be much smaller. The orthodromic and antidromic will give you similar results for the onset latency and the peak latency, but they record significantly different amplitudes as seen over here. The take-home message is that you can use any method, antidromic or orthodromic, but you must use appropriate reference values. When we did the proximal stimulation in motor nerve conduction, we get a response that is very similar at the two stimulation sites. That is not the case in sensory nerve conduction. You get a much lower amplitude response with proximal stimulation. The amplitude will decrease more as we increase the distance between the stimulation and recording sites. This low amplitude is not an indication of pathology. This is inherent in sensory nerve conduction studies. And therefore, we typically do sensory nerve conduction studies distally. We can also calculate the conduction velocity from a single stimulation. Sensory responses often have an initial downward deflection. If this was, imagine, a motor nerve conduction study, I would have placed my marker at the first deviation from the baseline. That is the convention in motor nerve conduction. But in sensory nerve conduction study, we measure the onset from the beginning or the rising edge of this upward going deflection. These are some of the technical differences that I want to emphasize. Otherwise, the patterns are the same. You get increased latency due to demyelination or loss of fast axon. Increased velocity, again, that would be a measurement error. It cannot happen due to pathology. You can have reduced velocity due to demyelination, loss of fast axon. Amplitude doesn't increase, but you may get a false sense of high amplitude if the limb is cold. So we always need to measure temperature. And temperature measurement is very important because it not only affects amplitude, but it can also affect the latency and conduction velocity. So you may get an increased latency with a very high amplitude because of a cold limb, and that can mask an axonal disease process. Similarly, you can get loss of amplitude due to loss of axons and increased temporal dispersion. The increased temporal dispersion is a little difficult to measure in sensory nerve conduction as compared to the motor. So here is an example of a carpal tunnel syndrome. When we stimulate at the wrist, you can see we have got increased latency. The amplitude is low. When we stimulate distal to the carpal tunnel, we have normal latency over here. It is very common to compare conduction studies among different nerves in sensory nerve conduction. This is often used, for example, in the study of tarsal tunnel syndrome or carpal tunnel syndrome. We know the thumb has dual innervation. It is supplied by the median and radial nerve. So if we were to stimulate at identical distance, let's say at 10 centimeters, we expect them to conduct at the same speed, and their latency difference should be very small. But in pathology, for example, in carpal tunnel syndrome, the median nerve will conduct slowly, radial nerve will conduct fast, and as a result, the median latency will be significantly increased compared to the radial nerve. So here is a normal situation. Radial and median have the same latencies, but in carpal tunnel, we can see the increased latency. So comparing different nerves is also a common strategy. It is frequently used in sensory nerve conduction. For example, median and radial conduction to the thumb, or we can do the median and radial conduction to the ring finger, or we can do the transcarpal median and radial comparison to detect carpal tunnel. We can also do the motor comparison. For example, one can record from the lumbrical and the interosseous muscle at the same time by stimulating the median and ulnar nerves. In axonopathy, the pattern is very similar to the motors. We get a significant drop in amplitude with normal latencies and velocities as shown over here. And whenever you have a very low amplitude response, one must always average the responses. Otherwise, you will overestimate the amplitude due to noise, and you may miss pathology. Sensory nerve conduction studies are extremely useful for localization. So in this case, you can see this is my spinal cord. This is the dorsal root. This is the dorsal root ganglion. And this is the ventral root. So these are the motor fibers. These are the sensory fibers over here. If I had a lesion radiculopathy in this area, notice that my dorsal root ganglion are not affected. And as a result, my sensory nerve conductions will be normal, but my motor nerve conductions will be abnormal. In contrast, if I had a plexopathy, the lesion is distal to the dorsal root ganglion. Now I'm going to get abnormal sensory nerve conduction as well as abnormal motor nerve conduction. Sensory nerve conduction studies tend to be a little bit more challenging because of low amplitude, but I like them because they are useful not only for localization, but they are also more sensitive, for example, to study demyelination. I think because they do not involve the neuromuscular transmission, we can purely assess the speed of conduction, which is a little bit more challenging in motor. And I think that's why sensories are more sensitive in polyneuropathies compared to motor. Again, that's my hypothesis at the moment. So we can do sensory nerve conduction studies in many different nerves. I have listed the recording sites for median and radial and ulnar. This is something that is very nicely described by Professor Asa Wilborn in the diagnosis of plexopathies. And by choosing the appropriate nerve, we can localize the lesion to the appropriate trunk or the cord. So the sensory nerve conduction tells us again something about excitability, propagation characteristics, size of the axons, and this is most useful in localization. Now I'm going to take 5 minutes before we conclude to describe F waves. They are recorded, were recorded first in the foot muscles and therefore the name F wave. The F wave originates as follows. When we stimulate the axon, the action potential goes both ways. The direct approach to the muscle produces the M wave, but we can also have antidromic propagation, which reaches the spinal cord, and there's a small chance it can reactivate the anterior horn cells. And this gives a response back. It comes along the nerve, and that is something we call the F wave. It is important to note that the number of axons that respond to this arrival of action potential is very small, maybe 1 to 2%, plus it will be different motor neurons that respond every time. So the F wave is a long segment study. We are looking at conduction over a long pathway. Motor is a short segment study. Motor is a distal segment. F wave is a proximal segment. M wave is a sum of all motor unit potential, and therefore it stays constant on successive stimulation. F wave is summation of a few motor units, therefore the response is smaller and it's variable, and sometimes it may not occur at all. It is important to note that F waves looks at propagation in proximal segments and therefore can give complementary information to motor nerve conduction studies. One typically measures the minimum latency. So we stimulate the nerve a couple of times, typically 10 times, because the response is variable. We can superimpose the traces, that's what I like to do, and measure the latency of the earliest F wave. One can also look at the statistics of various measurements, such as latency, amplitude, etc. And that can give us some non-specific useful information, as I will describe soon. But in terms of electrodiagnosis, we measure the latency of the earliest F wave. The latency is increased because of demyelination, and it can also increase due to loss of fast axon. Although we don't measure the amplitude, visually we can see higher amplitude with renervation or hyperexcitability, and it can be small due to loss of muscle fibers and atrophy. Again, I emphasize Most of our analysis is based on latency, not on amplitude or other things. Another important parameter is the persistence, uh, which tells us the hyperexcitability or lack of excitability. You can get fewer F waves due to loss of motor units, or you can also get fewer motor units due to conduction block. So to my mind, the latency is useful to study demyelination, but the other parameters such as persistence and amplitude and waveforms give us a lot of useful information that can be analyzed to get extra information. So let's start over here. Here I have stimulated the nerve many times, and when I superimpose the responses, you can see this waveform is not changing. This is something called an A wave. This indicates abnormal conduction in one axon or maybe one or two axons. It is important to note that A waves can be seen in the tibial nerve of healthy subjects. We ignore them. We don't overinterpret them. The A waves, the waveform remains constant on successive stimulation, same latency. This can occur anywhere in the recordings. It can occur after the CMAP and before the F waves. You can see A waves within the F waves, or they may come even later. There is no specific place where they can occur. Sometimes you can see responses where they are reproducible, but they don't occur on every stimulus. These are called repeater F waves, and these are often seen in patients who have lost motor units. Because there are only a few motor units left to generate F waves, we can recognize their motor unit potentials easily. Here is our analysis with Professor Barkhouse, number of repeater F waves with compound muscle action potential. And in patients with ALS, it is not uncommon to see the repeater F waves. I would like to emphasize they are not specific of any disease. This is just the data from our patients. Nevertheless, this gives us a clue when we are doing nerve conductions and we see repeater F waves that maybe this patient has reduced number of motor units and renervated motor units. And if you have lost a lot of motor units, you will have reduced number of F waves. So this is a typical F wave study on the right, where you get an F wave on almost every stimulus. And on the left-hand side, the F waves are gone. You can also see that the amplitude over here is much less. I'm at 500 microvolts per division. Over here, my CMAP is shown using 5 millivolts per division setting. Here is renervation. On the right-hand side, you can see F waves with normal amplitude and latency. Here is a patient where we can see the F waves are much higher in amplitude and the waveform is much more complex, though the latency is normal. So it is in this way, F waves can give us some supplementary information about the state of motor units. Here is a slide that I borrowed from Professor Stolber. You can see the F waves in a normal subject over here. They have low amplitude. Sometimes they are missing. And here is a patient with spasticity, where we get an F wave on every stimulus, and it is very huge in amplitude, as you can see over here. So this is an indication of increased spasticity. So in this manner, F waves also give us a lot of useful information. So we have gone over motor, sensory, and F wave. H reflex also gives us information, but it is used in relatively few situations. You can record it only in the tibial nerve. This is something I wanted to indicate. The orientation of the stimulator in F wave really doesn't matter. The convention says that anode should be distal in F wave studies, but that's really not important. So here you can see F waves, they look very similar, but in fact, if you look carefully, I changed the anode cathode polarity, which affected the CMAP latency, but did not affect the F waves. F waves are most useful, are the most reproducible measurements. Yeah, they are used in serial investigations. They are long segments, so they are useful to study diffuse pathology, for example, diabetes. They are also very useful to study in Guillain-Barré patients because they represent proximal segment study. And as I indicated, this is most useful as a cross-check in nerve conduction and needle EMG. So to summarize, nerve conduction studies can localize the lesion, it can characterize the lesion, and it can help us assess severity. Keep in mind that the reference values will depend upon your technique, but they will also vary by age, height, gender, and body mass index. Watch the waveform, but even before you watch the waveform, watch the muscle when you are stimulating. It is important to watch the waveforms to assess artifacts and to look at subtle changes in the waveform, such as the presence of extra peaks that may indicate demyelination. Correlate the physical measurements with physical examination and history. Isolated abnormalities should not be overinterpreted. And know the limitations of the technique. For example, if you have motor nerve conduction studies, we have a very broad range of measurements. We have got volume conduction. We are looking at primarily the fast conducting axon. We cannot study the slow conducting fibers and so forth. And by having a better understanding of how the waveforms are generated, how they are measured, how they relate to the underlying physiology, nerve conduction will be a much more powerful tool in your clinical EMG laboratory. So thank you very much for your attention, and I will be happy to take any questions.
Okay, I'm so happy for this very informative presentation, as usual, Dr. Nandedkar. So it's very simple way to explain a lot of waveform identifications in motor and sensor, and as well as delayed response. So I will start with my question in thoracic outlet syndrome. The patient clinically, he is have a pattern of dermatomal affection of the lower trunk, TH and T1. But may, when referred to electrodiagnosis laboratories, we get normal finds. How can we matching or how we can get explanation? It is a matter of time or something else in selecting a proper nerve to examine?
Okay, that's a very good question. As I indicated earlier, just because a nerve conduction study is normal doesn't mean that there is no pathology. All it means is that if you get normal conduction studies, then the pathology is proximal to your most proximal site. That's all we can say from nerve conduction. So that's why we should go as proximal as we can. It is not always possible. But it's an inherent limitation of nerve conduction. We can only comment on something distal to the most proximal segment. So normal conduction study doesn't rule out pathology. All we can say, it is proximal to where I studied and I cannot localize it.
My second question is the sensory nerve action potential in definite localization from radiculopathies or plexopathies. In some cases of radiculopathies, especially L5 or S1 root affection, we can find the abnormal snap. How can you explain this?
Okay, in radiculopathy, the lesion is proximal to the ganglion.
Yes.
And so in principle, your conduction study should be normal.
Yes.
Yes. So if you get a lower amplitude, maybe there is another superimposed pathology. Maybe the patient also has carpal tunnel. They came for C7 radiculopathy, neck pain, but they also may have carpal tunnel, so which can give you a abnormal latency. Or it can be a technical issue that we may have overlooked. But based on the anatomy, if it is radiculopathy, then our sensory nerve conductions should be normal.
Right. Okay. I think my last question is if we've Professor Kimura mentioned the value of the velocity. If we velocity, the distal and was at the proximal stimulation, and then get the proximal, the conduction velocity. And what about this impact for each pathology?
Okay. The F wave latencies should be assessed in relation to the height. Because as I indicated, when we stimulate at the wrist, the action potentials will go to the spinal cord and come back. And that distance is going to be longer in people who are tall versus people who are short. So the F wave latencies will be dependent on each subject. So there are two strategies of assessing F waves. One is to define your normal limits based upon height. So you can have nomographs. The second approach is to calculate the F velocity. So there is a formula. You can take the F minus M minus 1 divided by 2, or 2 times the distance divided by F minus M minus 1. And so you estimate the conduction velocity of the proximal segment, and then you compare it with respect to the distal segments. So those are the two strategies to assess the normality of F responses by taking into account the patient's height. But you're absolutely right. If you're going to assess F wave recordings, either compare the latencies based upon the height, or calculate the velocity and relate it to the patient's age and the distal conduction velocities.
No, thank you. I think you can check Q&A box. Dr. Sanjeev, yeah, you can see? Okay. We have first question. I don't know what he mean, how this distance comes. If you can explain what he mean. The second question from Heba. Yeah.
The distance is measured from stimulation site to the rough location of the root. So you will measure it to the spinal cord at appropriate spinal process. So that's the way you will measure the distance if you are calculating the F wave velocity.
The second one, how to differentiate repeater F from E wave?
The repeater F wave will typically not happen on every trace. I mean, there is a possibility, but A wave will happen on every trace. The repeater F wave will happen on some traces. It may not happen on some other traces. And typically, the repeater F wave tends to have a normal latency compared to A wave, because the repeater F wave is actually going all the way to the spinal cord and coming back. So it is buried within the F waves. The A wave is typically generated somewhere along the nerve, not all the way to the spinal cord. And so that tends to have usually a short latency. So those are the two things that will differentiate it.
And I think Professor Starling mentioned that the repeater must exceed 7 repeaters to be pathological. Yeah. The number of repeaters. Yeah. Murad, reversible conduction failure.
Can you repeat the question?
Reversible conduction failure. I don't know what he means. Reversible conduction failure. I don't know what he means. If you can, Murad, explain what do you know? What do you want? The other one, how to diagnose the C carpal tunnel syndrome in peripheral neuropathy. I think in superimposed carpal tunnel as well as superimposed peripheral neuropathy.
No, I still didn't follow the question. Sorry.
How to diagnose carpal tunnel syndrome in cases of peripheral neuropathy as well.
Okay. So the question is, how do you... So there are multiple approaches that have been used. Some people, for example, there is one technique where you look at the carpal tunnel, where you make a comparison between, say, the ulnar and median conduction study to the ring finger. Okay, so perhaps I come back over here. Let me show you this example over here. Like this approach over here, where we look at the latency difference between the radial, and we have a normal limit, something like 0.5 milliseconds. So in healthy subjects, we accept 0.5 milliseconds as the limit. But if you also have suspicion that the patient has polyneuropathy because of diabetes, then some laboratories will make this limit twice. So if the difference is more than 1 milliseconds, then they will say in this patient with diabetic polyneuropathy also has carpal tunnel syndrome. So that's one strategy of doing it. The second strategy is what is called 14-7 technique. So let me come back over here. So typically we stimulate over here and record over here. And it is a common practice to use a 14 centimeter distance. Now we make additional stimulation. We also stimulate in the mid-palm at 7 centimeters. So if it's a normal subject with carpal tunnel syndrome, your latency over here to the 14 centimeters will be increased. But this portion over here, which is distal to the carpal tunnel, will be normal. So in a patient with polyneuropathy and carpal tunnel syndrome, your latency will be increased over here. But when you look at the difference in the two segments, again, you will see it is not 50-50. It is more in this proximal segment to the distal segment. So that's the 14-7 centimeter technique that is used. You essentially break the nerve into two compartments of 7 centimeter and compare the conduction. So overall, the conduction is abnormal, but you can also see it is much slower over here compared to here. Yeah, so Ernie Johnson has published a method which is called 14-7. You can use that. And that is useful when there is also a superimposed polyneuropathy due to diabetes.
Routinely, we use one shot in stimulating the sensory nerve, peripheral nerve. So we get one single snap. We do not need in proximal stimulation due to the high of evidence or incidence of phase cancellation, as you know. But I think in some labs, we use distal sensory as well as the proximal sensory. So what is the benefit from proximal stimulation in pathological cases?
Okay. So if you are looking at a polyneuropathy, going proximal is not going to help. But if you are looking at focal neuropathies, then proximal stimulation can help. So it is not uncommon, for example, to do a sensory nerve conduction study across the elbow to localize the lesion. So again, it is not typical, but we do use it. I'm not saying it is never used. It is for specific conditions that we will use proximal stimulations. And what you can demonstrate in those recordings is what Professor Kimura used to call a nonlinear decrease in amplitude to localize the pathology. Yes, we do use proximal stimulation in ulnar neuropathies at the elbow.
Okay. I think this is the end. I'm really so thankful for your time and your effort and this great presentation. And I hope a lot of webinars in next future. Thank you, Dr. Sanjeev. Again, thank you for Technia company for this link of Zoom and this sponsorship. Thank you so much for the attendees. Thank you, Dr. Sanjeev. Okay, bye-bye.
My pleasure.
Okay.
Take care.
Thank you. Okay,
thanks.
Bye.
Bye.